Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers and specialists come together to learn about high-risk pregnancy conditions, share experiences and work together to ensure the best health outcomes for mothers and babies. Today we are learning about the identification, treatment and management of the high-risk pregnancy condition, jaundice, in pregnancy. But first, let's meet our expert trainers.
Hello everyone. I am Dr. Karishma Thiryani, a senior obstetrician and gynecologist practicing in New Delhi. As obstetricians or healthcare workers taking care of pregnant women, we have all encountered cases of liver disease in pregnancy. So we know that management of a woman with liver disease in pregnancy is a common but challenging clinical scenario. Mainly because the clinician needs to consider not only the needs of the expecting mother, but also that of the unborn child. Also, due to the physiological changes of pregnancy, sometimes the liver test, even in normal pregnant women, may seem to be abnormal, due to which it is extremely important for the clinician to have a very high degree of suspicion so as to accurately be able to diagnose these disorders. So, today, to help us understand the complexities of liver disease in pregnancy, we have with us Dr. Poonam Tara. Ma'am is a senior consultant, maternal and fetal health at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Dr. Karishma.
Thank you so much for joining us. Ma'am, please tell us, what are the signs and symptoms that are indicative of jaundice or liver disease in pregnancy?
So the ANM, once she sees a patient, has to take a detailed history, which should include the symptoms of particularly of jaundice in pregnancy, which includes fatigue, nausea, vomiting, which has not got any reasons. The patient may complain that she has been having pale stools or the urine is dark colored. She has an upper abdominal pain. So these are the common symptoms in pregnancy with jaundice. On examination, she could find icterus, which is the yellowish discoloration of the sclera pallor, which is, a pale, again, the conjunctivas. She can also examine the abdomen and may find that the liver is bigger, which is the hepatomegaly. And sometimes it can present with rash, particularly the petechial rash, which are the red flat rashes on the skin. So a combination of these, along with fever, headache, muscle pain, just a generalized body ache, should inform the ANMs to refer these patients to the doctors immediately so that it can be looked after in more details.
Dr. Poonam, please tell us that once an ANM thinks that the woman may be suffering from liver disease and she is referring the patient to a medical officer, can she at the same time provide the patient with some sort of supportive management?
Yes, sure. The ANM can emphasize the fact that she needs to have a lot of water, at least about 8 to 10 glasses of water a day. She should take adequate rest. If the fever is there and more persistent, more than 100.4 degrees, she can have paracetamol 500 milligrams 3 times a day. The combination of having a lot of fluids, good diet, which should include any complex carbohydrates like rice and potatoes boiled, not having oil in the food, so avoid oily food, avoid even the proteins rich food as well. So a combination of all of these should help the lady until the time that she is referred further.
This is a very important message, Dr. Poonam, especially in the field where the healthcare workers do not have easy access to medication. I think supportive treatment plays a very important role. And it comprises of such simple things like adequate rest, keeping yourself well hydrated, having a good carbohydrate-based diet, avoiding fats and proteins. This will really help the ANM to take care of the patient by the time she reaches the medical officer or a higher facility. So, Dr. Poonam, once the ANM refers the patient to a medical officer, what should be the medical officer's approach in taking care of such a patient?
So, the medical officer should start with a detailed history, asking particularly about the history of nausea, vomiting, malaise, anorexia, fever, headaches, abdominal pain, dark color urine, pale color stools. So all these history taking has to be taken and documented, followed by the examination, which is by looking for icterus, yellowish of the sclera, pallor, checking the abdomen, feeling for the liver, and then also doing the examination for the obstetrics point of view, which is looking at the symphysiofundal height and the fetal heart. Once the history taking and the examination is done, blood has to be sent for investigations, so which should include liver function test, kidney function test. Coagulation profile is also very important to check. Even the reticulocyte count and hemolysis in the peripheral blood smear can give us an idea if the liver functions are on the rise. So all these tests, which includes the CBC, the most commonest test, which should be done. And after getting the results of these, if the liver function tests are on the higher side, upper abdominal scan to check for liver, pancreas, the gallbladder should be done. And depending on where the problem is, referral to the gastroenterologist and to the higher centers needs to be done.
Dr. Poonam, what are the common causes of liver disease or deranged liver function test in pregnancy?
Causes are, Hyperemesis gravidarum, which is the commonest one, although pregnancies up to 2% land up having a severe hyperemesis gravidarum, which is excessive vomiting in pregnancy. This is usually seen in the early parts of the pregnancy up to about 20 weeks. There are certain pregnancy conditions where it is more, for example, the twins, vesicular mole. Sometimes a woman, if she's not feeling very well, can also present with hyperemesis gravidarum, and this has to be again investigated, and if the patient is found to be severely dehydrated, has to be admitted to monitor for any ketones in urine, check for sodium potassium, which is the kidney function test, and monitored thereafter. The second cause could be infections, which is the hepatitis B, C, E. Particularly the hepatitis E in pregnancy can have a serious maternal mortality as well as the fetal mortality. Any hepatitis per se has to be monitored in conjunction with the specialists, the gastrointestinal tract, who are the gastroenterologists. As the liver function rises and certain problems arise, for example, the coagulopathies, which can be troublesome to treat. So investigations can land us or tell us what exactly is the problem. Any of these has to be monitored, as we said, in the hospitals with the care of the baby as well, along with the mother. This is the second commonest or second cause of having jaundice in pregnancy. Then there are certain conditions which can come with one of the most commonest problem in pregnancy, which is the hypertension. So there is a condition called as a HELLP syndrome, which means that there is a hemolysis in the blood with low platelets count and elevated liver function test. This can also present with jaundice. This can happen in about 20% of women who have high blood pressure with proteins, which is the preeclampsia. And this has to be monitored in the hospital because it has implication for the mother plus the baby. So HELLP syndrome has to be diagnosed first, and in a multidisciplinary setup should be monitored and managed. There is another condition which is called as the acute fatty liver in pregnancy, which thankfully isn't very common, but it is a dangerous condition because it can have implication again on the maternal health and the baby's health. This is a condition where there is a fatty infiltration in the liver cells, and this can make the liver enzymes rise higher. Even the blood pressure can present simultaneously. In fact, about 50% of women can have issues with the blood pressure. Again, this kind of monitoring has to be for the baby and the mother and should be done with the specialist. So these are the common conditions where bilirubin can be high, the liver functions can be high, and must need to be monitored with the specialist. So one of the commonest condition of increased liver enzymes in pregnancy is called as intrahepatic cholestasis of pregnancy. This is a condition where the women presents with excessive itching all over the body, particularly in the palms and the soles. If such a condition happens, which usually happens in the second and third trimester of pregnancy, liver function tests needs to be done along with bile acids, and this has to be monitored in a tertiary level center with the obstetricians and the gastroenterologist together, because it has implications on the maternal and the fetal health.
Thank you, Dr. Poonam, for such a detailed description of different differential diagnoses. So just for the sake of simplification for the healthcare workers, all the differential diagnoses can be divided into two headings. One is the infectious causes like hepatitis, like Dr. Poonam explained. Hepatitis is very common in our country, especially hepatitis E, which needs to be really taken care of in pregnancy because it can lead to extremely high maternal mortality. Then the other set of causes are causes which are because of the pregnancy. These causes may range from common conditions like Hyperemesis gravidarum, that is excessive nausea and vomiting of pregnancy, which will usually present in the first trimester. All three, the IHCP, the acute fatty liver of the pregnancy, and HELLP syndrome are sort of obstetric emergencies because they have a huge bearing on the maternal and fetal morbidity and mortality. So as far as the peripheral level healthcare workers are concerned, that is the ANMs and the medical officers, it is good if they know about these conditions, but these conditions will be appropriately diagnosed and managed only at a tertiary care center. So if a medical officer is suspecting any of these conditions, they have to immediately refer such a woman to a higher center. So Dr. Poonam, my last question to you is, once a patient is referred to a tertiary care setup, how does her management change, or what does the specialist do to manage a woman with liver disease in pregnancy?
Pregnant women and their families who has had jaundice in pregnancy need to understand and have to be counseled that this is a high-risk pregnancy which has an implication on the maternal health and the fetal well-being as well, needing further management and monitoring by the specialist in a multidisciplinary center, preferably in the tertiary centers where there is availability of the specialist and the gastroenterologist. There is no indication for a cesarean section. Cesarean section should be reserved for obstetric indications, preferably a vaginal birth, and the baby, once delivered, needs to be examined by the neonatologist. Active and passive immunization is practiced here, where the immunoglobulins are given to the babies along with the active immunization with respect to giving the normal vaccination for hepatitis B.
Thank you so much, Dr. Poonam, for simplifying such a complex topic for our audience. Thank you.
Thank you, Karishma.
From today's discussion with Dr. Poonam, we have understood that diagnosis and management of liver disease in pregnancy is complex and challenging. But if we take a thorough history, do a detailed examination, and keep a high level of suspicion, we will at least be able to pick up women who are at high risk of developing liver disease and refer them timely to a higher center where they can be diagnosed and managed properly, so that complications like coagulopathy, encephalopathy and liver failure in pregnancy can be prevented. To know more about management of liver disease in pregnancy, please refer to our protocols. Thank you.
That brings us to the end of this training session about the identification, management and treatment of jaundice in pregnancy. Remember to refer to the high-risk pregnancy management protocol for more details.